Good evening. Today's topic is prediabetes. The reason I took this one because it is a toxic cardiometabolic state associated with lots of microvascular and macrovascular complication. Based on hemoglobin A1C, 33.6% outpatients had prediabetes from the survey done in 2015. The important thing is only 1% of them were recognized as prediabetes by the clinicians. Out of the out of that 1%, only 23% had documented treatment. That means the vast majority of them were, even though they had hemoglobin A1C results, they were not treated appropriately, either by lifestyle modification and or by metformin. What is prediabetes? It is intermediate stage of glucose dysregulation that may precede type 2 diabetes. The prediabetes affects approximately 720 million worldwide. It is estimated to become 1 billion by 2045. So in another 20 years, it will be 1 billion people will have prediabetes. In the United States, 10% of people with prediabetes progress to having a diabetes each year. This is the statistics I took from American Diabetic Association. As you can see, 1 in 3 Americans have prediabetes. If the patient is more than 65 years old, the chances are 1 in 2, 50% of them have prediabetes. Among men and women, men have higher incidence of prediabetes than women. How to diagnose prediabetes? There are 3 organizations that have come up with their own criteria to make the diagnosis of prediabetes. All these 3 included fasting glucose level, impaired glucose tolerance, and hemoglobin A1C. Even though they use those 3, one should remember hemoglobin A1C may become unreliable marker under certain conditions. Like when there is a coexisting or underlying hemolytic anemia, iron deficiency, hemoglobinopathies, pregnancy, and uremia. In those circumstances, hemoglobin A1C may not be the reliable marker. So how do the prediabetes will not have any signs and symptoms? That means one need to screen to find out whether the patient has prediabetes. United States Preventive Service Task Force came up with screening criteria. The screening needs to be done every 3 years in adults aged 35 to 70 who have overweight or obesity. American Diabetic Association criteria is every 3 years on all adults aged 35 and up, regardless of the risk factors. Both of them recommend using fasting blood glucose, hemoglobin A1C, and 2-hour postprandial glucose. This picture shows the criteria by American Diabetic Association, World Health Organization, and International Expert Committee. Since ADA criteria is being the latest 2023, we'll stick to that one. Fasting blood glucose, 100 to 125, 2-hour postprandial, 140 to 199, and hemoglobin A1C, 5.7 to 6.4. Fasting blood glucose alone can identify prediabetes in 28.3%. Hemoglobin A1C alone, 21.7%, and 2-hour postprandial glucose, 13.3%. What is the pathophysiology? How does a prediabetes happen? Prediabetes who have impaired fasting blood glucose tend to have higher or inappropriate endogenous glucose production because of hepatic insulin resistance, reduced hepatic glucose clearance, or lower ability of the glucose to stimulate its own uptake and suppress its own production. Patients with impaired fasting glucose also have impaired beta cell function. So impaired glucose tolerance predominantly by skeletal muscle insulin resistance, that means delayed glucose uptake, and also beta cell dysfunction. With a near maximal insulin resistance, the beta cell function goes as low as 80%. That means 80% of the beta cells doesn't work. That means greater impaired glucose tolerance. The prediabetes incidence is 6.2% among white population, 7.8% in Pima Indians, where there is increased incidence of diabetes, and 11% for those with the parental history of type 2 diabetes. When there is a genetic predisposition, the incidence is much higher. There is no racial predilection. It is the same amount in black and white. The normal glucose regulation to prediabetes is associated with increased body weight and insulin resistance, and combined with endogenous insulin secretion response to glucose. So those two predispose them to move from normal glycemia to impaired glucose tolerance. So what are the risk factors? Overweight or obesity, older age, physical inactivity, unhealthy diet, genetic predisposition. US survey shows the prevalence is 38%. International Diabetes Federation estimated global impaired glucose tolerance is 10.2%. I think it's a gross underestimate in my opinion. So what are the complications in persons with prediabetes? Number one, progression to diabetes. The annual rates of progression from prediabetes to diabetes range from 5.8% to 18.3%. Age of prediabetes onset influence rate of progression, meaning the younger the age you diagnose prediabetes, the chances of moving to diabetes is faster and higher percentage. If the prediabetes was diagnosed after 60 years, lower the rate of progression. There is no ethnic or racial preference or difference for the progression to diabetes from prediabetic. Second complication of prediabetes is microvascular and macrovascular complications. Prediabetes have more cardiovascular risk factors than people without prediabetes. Number one, it has more cardiovascular events, high mortality risk, impaired glucose, impaired fasting glucose, impaired glucose tolerance, and increased hemoglobin A1C. And these patients, pre-diabetics, have higher rates of hospitalization than normal glycemic patients. The retinopathy is, incidence of retinopathy is 7.9%. With its incidence of neuropathy is 7.5 to 16%. Nephropathy is 9.7% among pre-diabetics. These patients are not diabetics yet. And also these patients, pre-diabetics, have a higher frequency of impaired cognition. So pre-diabetics is not just a number, it has an influence on other systems and also on the cognitive side. Third thing that could happen is spontaneous remission of pre-diabetes. The resolution of pre-diabetes occurred in 33% to 59% of individuals within 1 to 5 years of follow-up. This is truly a good news. That means the potential of reversing pre-diabetes to normal glycemia is possible if you identify and treat them or advise them appropriately. The spontaneous remission is less when there was a longer follow-up. 6 to 11 years follow-up shows remission is 17 to 42%. The rest of resolution decreased with the longer follow-up. Now, how do you treat prediabetes. The number one and the main line of treatment is lifestyle modification. That includes diet and exercise. The good thing about lifestyle modification is well tolerated without any major adverse events. What are the dietary changes? One should have balanced diet. That means rich in whole grains, fruits, vegetables, lean proteins, and healthy fats. Limit the intake of sugary beverages. That includes like pops and also the sugary drinks, including the juices, sweets, and refined carbohydrates. The portion control is very important. The portion sizes to avoid overeating. Fiber intake needs to be included because that helps to regulate the blood sugar levels. The fats are important, but healthy fats such as nuts, seeds, avocados, and olive oil needs to be included in daily dietary habit. Physical activity. Make sure these patients needs to have at least 150 minutes of moderate intensity aerobic exercise per week, such as brisk walking, cycling, or swimming needs to be happening in these patients. And resistance training exercises at least twice a week to build muscle mass and improve insulin sensitivity. And the daily routine physical activity, meaning taking the stairs instead of elevator or lift, walking during breaks, or gardening. These are all the daily routines promote the physical activity that again helps to reduce prediabetes or change prediabetes to normal glycemic levels. The weight management is very important. The modest weight loss of 5 to 7% of body weight if the patient is overweight or obese. It significantly reduces the risk of developing diabetes. Most of the time, it is not the higher amount of one-time work. Focus on long-term sustainable habits. If you continue to do, even if you do 3 or 4 times per week, meaning 3 or 4 times per week, you don't do it. If you continue to do over long term, that will reduce prediabetes. Sometimes it can convert from prediabetes to normoglycemia. And behavioral changes. Practice stress reducing techniques such as mindfulness, meditation, yoga, or deep breathing exercises. Sleep hygiene is very important. Ensure adequate and quality sleep. Aim for 7 to 9 hours per night. Poor sleep can negatively affect blood sugar levels and insulin sensitivity. If you're a smoker, avoid smoking. It can increase the risk of diabetes and other complications. Regular monitoring is very important. Regular monitor blood glucose levels to track the progress and make necessary adjustments. Sometimes the diet you think it is working or right may not be the right. The exercise you think you're doing enough is not enough. Only by following regularly, you can make an adjustment, either increase or decrease. Medical checkups are necessary, regular visits to healthcare providers to monitor and getting guidance. Education, part and parcel of treating prediabetes. Participate in diabetes prevention programs. There are DPP programs available in different countries, different ways, because nutrition and the diet differ from one place to another. Exercise more or less similar across the globe, and participate in support groups because people have same length of wavelength of the dietary habits and the exercise habits that will help you to motivate and share the experiences with others and learn from them. In most randomized control trials, the effects of lifestyle modification primarily mediated by weight loss. When you do the lifestyle modifications, aim for weight loss that brings down the prediabetes. The effects of lifestyle modifications it persist after discontinuation of the intervention. That is a good thing about lifestyle modification when compared to other pharmacotherapies. Pharmacotherapy can work oftentimes less than lifestyle modification, but when you stop the pharmacotherapy and prediabetes can happen or it can get worse. Lifestyle modifications not only reduce prediabetes and also it sustains. This is a little bit of bad news. Despite the improvement in cardiovascular risk factors with lifestyle modification like systolic blood pressure improves, LDL level improves, and triglyceride levels, it has not significantly shown to reduce nephropathy, retinopathy, and neuropathy. There are few reasons for it. Some of the studies were short enough to see the effect on these microvascular complications. Subclinical atherosclerosis have been seen in 75% in lifestyle group versus 84% in placebo group based on coronary artery calcium level. Even though it has reduced, but it's not very significantly reduced than the placebo group again, it could be because of shorter follow-up rather than longer follow-up on those studies. Another caution one need to remember is persistent prediabetes. The persistent prediabetes who do not progress to diabetes may still face increased risk of complications. Sometimes people may believe, hey, I am in a pre-diabetic range, I am okay. No, you are not. There is increased microvascular and macrovascular complications just being in pre-diabetes. The aim is to correct to normal glycemia. So what are the drug therapies beyond lifestyle modification? Compared with the placebo, metformin reduces the incidence of diabetes among people with prediabetes. But one I should emphasize, metformin is less effective than lifestyle modification. So lifestyle modification is the number one. In women with history of gestational diabetes, metformin with intensive lifestyle modification can prevent progression from pre-diabetes to diabetes. So what is the American Diabetic Association recommendation to use metformin? When the patient has a BMI greater than 35, less than 60 years of age, I want to emphasize, metformin in patients above 60 years of age have not reduced the mortality. So ADA recommends BMI greater than 35, age less than 60 years of age, women with history of gestational diabetes, those with higher fasting plasma glucose level more than 110 or higher hemoglobin A1C. These patients needs to be on metformin along with lifestyle modification. One should remember those who are in long-term metformin needs to be monitored for vitamin B12 deficiency. These are the various studies done to evaluate the effect on prediabetes. I want to show a couple of studies. IDDP1. It is Diabetics Preventing Program in Indian context. It was published in 2006. They used three limbs. One, lifestyle modification. Second, metformin. Third, lifestyle modification and metformin. What they found was diet and exercise reduce Prediabetes, 28.5% of the time. Metformin, 26.4%. Metformin alone, 28.2% after 30 months. That means after 3 years. The point here is diet and exercise alone is better than either two interventions. So adding metformin have not improved any more positive influence than diet and exercise, according to IDDP-1. The second, IDDP-2, again an Indian study. In this particular study, they used pioglitazone alone, pioglitazone with lifestyle modification, and lifestyle modification alone. And this study also showed adding pioglitazone has not added more value than just lifestyle modification, which was published in 2009. So these two studies from India shows lifestyle modification alone can do with or without medicine, and adding medicine have not shown increased advantage. I want to show other three more studies. The DREAM study that was published in 2003, I think it was published in Lancet and New England Journal of Medicine. When you add rosiglitazone, it's shown reduction of 62% prediabetes to normoglycemia in 3 years. But when you look at the patient population, median age was 54.7 and BMI was 30.9 in the excessive side. ACNO study used pioglitazone. Again, BMI was 33, median age was 53, and it showed 72% reduction in 2.4 years. Even though the numbers look good, but it works great in BMI when there is higher. I'm sure the Indian study didn't show that much of benefit because their BMI is not as big as in American studies. The third study is a navigator study, wherein they not only control the sugar and also control the blood pressure. The first one was nataglinide study to control the blood pressure and to see the effects on prediabetes. That has not shown any benefit. And there was another study, valsartan, and that was published in 2010. It shows 14% reduction in prediabetes. What I gather from all these studies, lifestyle modifications alone make a big difference. If you have an excessive body weight, adding rosiglitazone, metformin, or pioglitazone definitely helps, along with controlling blood pressure. So how do you approach to screening, diagnosis, and management of prediabetes? When you have a major risk factors for prediabetes, families have diabetes, older age, overweight or having obesity, physical inactivity, and history of gestation diabetes all need to be screened for prediabetes using fasting blood glucose, 2-hour postprandial, and hemoglobin A1C. As we saw earlier, all of them as a single parameter gives only 30%. Combination gives a little bit more evidence of prediabetes. And there are two American Diabetes Association says anybody 35 and 5 years needs to be screened every 3 years for prediabetes. Identifying prediabetes is very important, so screening is very important. When you screen, you can give appropriate advice and ask them to do lifestyle modification. That is the best way to control prediabetes or revert to normal. And the way you screen them is fasting plasma glucose, use 100 to 125 as a cutoff. 2-hour plasma glucose, 140 to 199, hemoglobin A1C, 5.7 to 6.4. and use metformin age less than 60. It's very important. BMI more than 35. History of gestational diabetes definitely will be helpful. Metformin really changes from pre-diabetes to diabetes. And fasting plasma glucose more than 110, hemoglobin A1C 6. And of course, if the patient preferred to have metformin along with the lifestyle modification, one can use. Whenever you use metformin therapy, make sure they have vitamin B12 supplementation or look for vitamin B12 deficiency. Lifestyle intervention is very important, even though it is easy, but having somebody monitor their lifestyle modification that will keep them on track. Frequent in-person visits and followed by less frequent visit with the optional virtual visit. Initially in-person visit, then over time you can make them as virtual visits. Second is dietary modification, decrease caloric intake, 700 kcals per day, and make sure they eliminate saturated fats and simple sugars. Physical activity, 30 minutes per day, 5 or more days per week. That needs to be as a routine. It is like brushing your teeth every day morning, having walk in the morning, brisk walk, and walk in the evening. Or if you have to go to work in between during breaks, having walk around the office or around the building, so on and so forth. Using stairs, self-monitoring, record food types, portion, calories, minutes or activity or steps taken each day. The problem with self-monitoring is self. So having somebody oversee the patient will get better results than they do themselves. Weight loss goals are individualized, but having reduction in body weight more than 7% definitely helps to move from pre-diabetes to diabetes. If somebody is a smoker, they need to stop smoking. If they are not smoker, they should not start smoking. Sleep hygiene is very important. Sleep deprivation causes insulin insensitivity and changes pre-diabetes to diabetes, even the causation of pre-diabetes. And stress reduction techniques needs to be practiced every day. So in conclusions, pre-diabetes is a toxic cardiometabolic state associated with microvascular and macrovascular complication. I want to stress, even when they have not moved to diabetes, pre-diabetes alone can cause microvascular and macrovascular complications. So diagnosing early and treat them appropriately will stop the progression to frank diabetes and also reduce the complications arise from it just from pre-diabetes alone, and easy to stop rather than dealing with frank diabetes. So clinicians should diagnose early and treat pre-diabetes. As I had shown earlier, in 2015 study done in United States, only less than 1% of those who had pre-diabetes was treated appropriately. So lifestyle modification works better than medications and it has a long lasting effect. But when there are indications, special indications, one should not afraid to use medications to stop the progression. This concludes the seminar on pre-diabetes. Any questions?